Good morning, good afternoon, good evening. I think it's a wonderful opportunity for us all to learn about taking a proper sexual history from a world's expert. My name is Jerry Brock, and I'm a urologist in London, Ontario, Canada. And I have the distinct honor and pleasure of introducing Dr. Charles Moser, who's both an MD and PhD. He is a sex researcher, sex educator, clinical sexologist, and sexual medicine physician who currently practices in San Francisco, California, in the United States. He's a pioneer in the field, and we're really delighted to have him here. He is president of the Diverse Sexualities Research and Education Institute, which is a nonprofit organization. He has a private practice that focuses on both sexual medicine and internal medicine. He's the author or co-author of more than 80 publications, and he is clearly a world expert. So the plan for the next 90 minutes will be that we'll initially have an opportunity to hear Dr. Moser talk to us about taking a sexual history and putting sex into the sexual history. After that 45 or 50-minute didactic talk, during which if you feel like you have a question, please feel free to ask the question for those of you who are active participants. For those who are not active participants, we likely will give you an opportunity to write in your questions later on in the program. After the didactic portion is complete, which will be like a virtual visiting professor in your home today, we will have a question and answer period for Dr. Moser. So the goals, of course, are to make this interactive, to be enjoyable, for us all to get better at taking a sexual history. So it's a real pleasure to introduce you, Dr. Moser. Please, why don't you begin your presentation?
Okay, thank you. Thank you very much. I'm very excited about doing this talk, and I'm very appreciative that the ISSM has asked me. You should know that I've been a member of ISM, I think, since its founding. Oops. And I want to be really clear. This is very difficult, and I'm going to suggest lots of things for you to do, and I don't expect everyone to accept everything. And I know that many of you are come from very different cultural backgrounds, so some of what I'm going to suggest may not be appropriate for you. Underneath all this, it says that working with patients requires a certain type of sexual cultural competence, and this is not even only related to sex, but different for diabetes and blood pressure control and all the other medical problems that we see. And I think we've said this before, the sexual medicine is what my definition, the medical aspects of sexual concerns and the sexual aspects of medical concerns. And we know that all diseases, procedures, treatments can affect the patient's sexuality and sexual functioning, and we should all be conversant with that, and we should be aware as sexual medicine physicians to clearly understand when the help educate our other physicians that we work with and the patient about how this happens, what happens. Now, I took this from the ISM website. I did have to adjust the wording a little bit because I took it out of context, but this is what being sex positive is, and I'm going to give you a chance to read this. And it's important that patients feel that they can tell us whatever the sexual concern is and be clearly open to sharing with us, and we have to set up an environment where that sharing is appropriate and the patient is comfortable telling us. And again, I'm not going to read my slides here, but I'm going to let you take a moment to read the goals. And part of the issue is that we want to make it very clear that we don't judge the patient and we don't make assumptions about the patient's behavior or gender identity, what their relationships are like. We let them tell us, and we hopefully can accept that non-judgmentally. And one more thing about my aims and objectives, and try and give you some pointers on how to do this without making assumptions and without stereotyping the patient. So sexuality includes, and again, I'm not going to read all of my slides here, but too often we think that sex is either something you do by yourself, something you do with one partner, many partners. It also relates to the gender presentations that patients have. You know, I cannot tell you, as I sort of perfected what I've been doing, how many times I made an assumption about a patient that I only found out later was completely wrong. I actually saw a patient who is a physical therapist in the hospital I work, who sought me out, I assume because of my attitudes about sexuality. And I assumed from her dress and presentation that she was a lesbian woman. And in fact, she was absolutely not lesbian. She was a very happily married woman to a man with several children. And I laugh about it as I think about how I made those assumptions, all based on her appearance, that were actually incorrect. I do want to jump to a moment where we talk about patients, and some patients are monogamous and some patients have many partners, and partners can be sexual partners versus emotional connections. If you don't understand the initialism here, NSA is no strings attached, people who are having sex because they want to have sex and assume that there's nothing else to it. FWB is friends with benefits. These are people who have ongoing relationships who may or may not have regular sexual contact. And patients who are committed in some way, committed is really the wrong term, but I couldn't come up with a better one, committed to each other, and sometimes more than one person, but an ongoing emotional commitment. And I want to also highlight here that we sometimes have to make a distinction between who the patient lives with and who the patient has sex with. And most importantly, and most oftenly forgotten, is who the patient's partner has sex with. And I'm often asked personally questions like, who is my partner? And I say, why do you assume I only have one? And people chuckle and walk away shaking their heads, I think. Gender is an area where the terminology is changing. And so we have this whole long list of terms. They're all different. I'm sorry I don't have time to go through each of them. And whatever I can tell you is in a few years, these terms will be outdated and no longer politically correct. It is sometimes a stretch to be able to keep up with the politically correct terms. And this is a little bit ahead of myself here, but we're trying, we have the honorific mix, which we'll talk about in a minute. And this is assigned male at birth and assigned female at birth, is the current way that we acknowledge people are what they say they are, male or female, even though their biology may have been different at birth. By the way, Even intersex patients will be assigned male or female at birth, and we should consider that. And as most of you know, when we started learning how to take a medical history, we would always say something like, Mr. Jones is a 32-year-old male who is in his usual state of health, and then go on with the history. And this gets changed in this way of viewing it to Mix Jones is a 32-year-old assigned male at birth who was in their, or we'll talk about that in a minute, usual state of health, and then moving on. A few more definitions. When someone says, I'm trans, I'm gay, I'm into BDSM, those can be an implicit basis of implicit bias and discrimination in healthcare. But we need to be aware that it does not imply behavior. Right? Behavior is what someone does. Interest and orientation are different aspects of the same thing, where what the person wants to do, but an interest is less fixed. It changes, it dissipates, it evolves, the intensity varies. Orientation is a much stronger, enduring form of sexual interest. I wrote this paper defining sexual orientation, which I attempted to analyze what those aspects of sexual orientation are. And we usually noted them to be an early onset. They exist lifelong. Lust is a sexual component. It's what gets people aroused. There is a relative immutability and a fluidity, all right? Meaning people do change, but that interest tends to stay, maybe varying a bit in strength. And the important part, or what I think is the most important part, is there are consequences if the person does not express their sexuality, their sexual orientation. And I have a few more definitions here. And again, I'm not going to read all of them, but try and give you a sense of how varied these interests are. And I point out this can be in heterosexual or diverse sexualities, sexual minorities. All these things can be applied to them, though sometimes they're the words are focused on certain types of sexual subcultures. Monogamish is usually that you can have sex only, you're monogamous, but can have sex with others in certain situations, when you're out of town, when you're on a business trip, only when the other person is, your partner has agreed, all sorts of things. Hall pass is a little bit different in that it allows people to say, I'm allowed to go out and have sex and these other things. I don't necessarily have to check with my partner. And these can be open, or what's called ethical or consensual non-monogamy, versus closed situations where that is not allowed. That can sometimes lead to cheating, the don't ask, don't tell, which is surprisingly more common than people think. My wife or husband knows that I have other sexual relationships. They don't want to know about it. They don't want me to tell them about it. Just let them, as long as I adhere to certain criteria, it's fine. We already talked about friends with benefits. Polyamory involves a type of many loves relationships. Swinging involves people who are having sex, presumably without emotional interaction, though in fact that often does evolve. And relationship anarchy is a term that defies definition because the people who defined it are anarchists themselves, but it's a type of whatever goes is okay. The V versus delta applies to threesomes or truples. They're now being called, as the two ends of the V do not interact sexually with each other. They both interact with the bottom of the V. Delta is everybody interacts with everybody. And of course, it can always be more than three, so there are groups. Relationships can be sexual or emotional. Important to make that distinction sometimes. And important in the same sense, it's important to know who the patient is partnered with, as well as who the patient has sex with. Aromantic are people who don't engage in romantic relationships. Asexual is people who say they don't have very much interest in sex. That doesn't mean that aromantic people don't have romances, and asexual people don't have sex, but it's, again, part of their definition or their self-identity. And chastity is actually an interesting concept. It's people who are often romantic, often sexual, but choose not to have sex or orgasms themselves. People may know that I have published a lot on BDSM, bondage and discipline, dominance and submission, sadism and masochism, and these are another type, another axis of sexual identity and behavior. I've listed a whole list of, again, gender diverse groups. They all feel very strongly about how they're defined, and you have to have some sensitivity to distinguishing them and adopting their usual sense, their usual definition as you take a history. And I want to be careful of stereotypes, MSM, men who have sex with men versus a gay man. The gay man has an identity, may involve behavior, may not. Men who have sex with men do have sex with men by definition, but may not define themselves as gay. And indeed, in my practice, I see lesbians who need birth control, people who tell me that they're monogamous, but then have other partners. The fluidity issue is, I talked about a bit before. These are people who identify as either gay or straight, but do have other relationships, and that's the fluidity of how they move. Sometimes talk about fluidity as age choice. When we're all in our teens and 20s, we tended to be aroused by individuals who are also in their teens and 20s. And we're in our 60s and 70s, we tend to be aroused by people in our 60s or 70s. But there are people who get stuck, and I don't mean this in a negative way, and even though they're 70, still like the 20-year-olds, and the people who are 20s have a particular interest in 70-year-olds who don't, and that doesn't change. Again, let's always remember that the past does not predict the future. And even someone who has been married monogamously to a person of the other sex for 30 years may decide to experiment with same-sex behavior or BDSM or non-monogamy or something else. We often make a a stereotype that the best example is porn. If you look at porn every day, you're a compulsive porn user. May not be true, and after a proper history, you may be able to find that there are situations where they were away from porn for years. It wasn't compulsive. It wasn't impulsive. It was, it's just something that is part of their sexual pattern. The assumptions are really sort of going back to my patient who was the physical therapist. You can't imagine the patient doing something because that's your own view, your own stereotype that fits into the system. And when someone comes in and says, I'm gay, I'm straight, that affects both your perception of the patient and the patient's perception of each other. And indeed, many patients will be looking for a physician or therapist who's fits their own perception of their sexuality. Again, I'm letting you read this. And it's important to understand that these stereotypes affect both the conventional and the sexually diverse. You know, it's hard to imagine asking your, 70-year-old woman if she still has anal sex or oral sex, because we stereotype people based on age and based on their appearance. And it allows us to miss diagnoses. A woman who I saw who was about 70, who had a sore throat, and she had some white exudate, and I was ordering an antibiotic, and she politely asked if the antibiotic would cover sexually transmitted diseases, which said a lot about her and a lot about how I needed to learn how to ask that question better. And it can lead to not asking patients sexual questions. I'm known to have, I did some training in a Catholic hospital that took care of a lot of nuns, and I was one of the crazy residents who asked nuns sexual questions. Of course, you have to do it respectfully, but sometimes nuns were doing sexual things that affected their health. Missing all of this results in poor care, and not recognizing where the patient is in their life, in their sexual subculture, you can really miss things. The definition of sexual health here is from the Pan American Health Organization. I think it was picked up by the World Health Organization. And we'll talk a little bit about this more, but it's more than what we normally think of as health in medicine. I'll let you read all these other things for a moment. In most medical histories, we're trying to recognize disease, start early treatment, understand what the patient's behaviors are that might lead to these. And sexual health is no different. But we also try to optimize sexual functioning and satisfaction with one's sexual choices. That is different. And I know I'm speaking to a group of sexual medicine physicians primarily, and Many of them are great. I've spent a lot of time talking to them, but they haven't trained their staff very well. And I recommend that what's worked for me is giving staff scripts to read. Many of these of our staff are trying very hard, but really don't have the background. I recommend that we put sexual medicine as a specialty on stationary advertisement websites, because I really want everyone to know when they come to me that they're seeing a sexual medicine physician. I realize that some of the patients are going to not choose to see me because of that, are going to avoid seeing me for that. And I also know that I get a lot of patients who have another primary care doc, but now have a sexual concern and come to see me. Those flags at the bottom, we call this the rainbow flag, usually depicts gay and lesbian people. The second flag with the pie is the polyamory flag. The next one is a bisexual flag. In the one with the heart is either called the leather flag or the BDSM flag. Of interest, the gay patients would call it the leather flag, and the heterosexual patients will call it the BDSM flag. The next flag is the trans flag, and then there's the non-binary flag, and then there's the asexual flag. Again,
Dr.
putting
Moser,
these on, yeah.
It's Dr. Brock. So far, I love your talk. I think it's terrific, and I must say that I'm learning a lot. But I'm sorry to interrupt you, except that you brought up a lot of really great points about the sexual history and being sex positive. And I must say, the question I had was, based on all of your expertise and the fact that many of the people who are watching this presentation are experts in the field and give talks of their own, who is it that you think should be taking a sexual history? Given the complexities and the subtleties that you've identified, is this something that should be in the realm of primary care, or should it be relegated to sexual medicine specialists?
I like to think that most primary care docs can do a rudimentary sexual history and know when to refer to sexual medicine physicians. But this is, as I said earlier, it's very difficult. And I don't expect most primary care docs to take an adequate sexual history. And when they run into problems, which I'll talk about in a couple of minutes, that's when it should trigger them, I really should be sending you someplace else. In the same way as, my understanding of cardiology or neurology, I can pretty much know when I need to send someone to a specialist, but I have to be able to take enough of a history to be able to tell the specialist, I'm really worried this patient's having seizures, or I'm really worried that this patient has a more serious neuromuscular disease. So I think everyone should be taking a bit of a sexual history and knowing when to refer. I hope that the sexual medicine docs out there will be able to sense when what this is and zone in on the more esoteric points of the sexual history. Did that answer your question?
Thank you. That was great.
And again, before the patient sees, before you ever see the patient, they see your forms. Again, I'm not going to go through all of these statements, but it gives a sense of how you take what's on your forms. I put partnered in italics here because when I first started, that was the biggest thing that people wanted, that they could be partnered without being married. And I had to say that. I think it's wonderful, and maybe because of ISSM and other reasons, this is now fit into the um, um, general lexicon of all physicians, that you can be partnered and not be married, and that can be a serious commitment. But it's important to note that, and patients still comment, "I'm so glad you put partnered on your form." Fluid bonded, sometimes patients don't know what that is. It means you share bodily fluids with your partner. And sometimes you're fluid bonded with one partner and not the other, or you're fluid bonded with your primary partner, but not the friends with benefits or others. Sometimes it's important to know that, because it leads to a risk of sexually transmitted diseases. The other little point that I'm going to make here is that safer sex rather than safe sex is probably a better term. And if people don't know what the PrEP, PEP, and TAS, pre-exposure prophylaxis, post-exposure prophylaxis, and treatment as prevention primarily have to do with HIV transmission. So when patients come in, they're given a clipboard where they fill out, their address and phone number and various other information. But there's a laminated card that's on each of those, which you're looking at. And it again tells patients that we have sensitivity to letting that patient define which pronouns they want, and you get to choose which honorific you like. And it immediately sets a tone for patients that, hey, this is a little bit different. We can open this up. There's a little bit of safety here to talk about other things, other sexual things. Years ago, I wrote a paper with my physician assistant, Maura Devereaux, and we were arguing that we should all be using gender-neutral pronouns, that we shouldn't just assume by the patient's dress and demeanor what their gender was. And so we came up with this these gender-neutral pronouns. And this is, in the literature, this has been something that people have talked about, and invariably it degenerates into some argument about which gender-neutral pronoun you should use. I really don't care. I just think that every practice or hospital system needs to choose one system and keep to it. And I've been trying to use these when I write letters, to get out of, for disability, or because patients are ill and need a work excuse. There's a little box that I put at the top of every letter that says this, so that, and then I try and use these gender-neutral pronouns and honorific. Again, this is to educate other people, the people who are reading it, the judges who are reading the letter to get out of jury duty, the human resources people who are reading the letter to excuse the patient from work, or become something useful. A lot of people prefer the use of they as a gender-neutral pronoun, and I don't disagree with that, but it can be confusing. I was working on with a psychiatrist, and we had a patient comment who was non-binary and had multiple partners, multiple polyamorous partners, and to top it off, they had multiple personalities, and so when they said they, we had no idea who they were talking about, and it could be very confusing. These pronouns don't always help that, but it's something to think about. Again, this gets very hard very quickly. And wouldn't it be great? I'm not sure that's really correct. It would be great or not, but it would be a step forward if we only use gender neutral pronouns in clinical notes, unless there is a reason not to. You know, we run into these things that can be hard to wrap our head around. Her penis, his uterus exist in the world because of how people define themselves, but can be very complicated, one to use correctly and consistently. And I want to be really clear that everybody makes mistakes. I'll admit to making mistakes myself. We all make assumptions. It's part of who we are as humans. And when you do it, you need to recognize it. You need to apologize. But I want to be clear, you don't want to make excuses. You don't say, oh, it said on the computer screen, you're male. No. I'm sorry, I used the wrong pronoun, my mistake, I'm sorry. And now everyone says, well, thank you very much for all of this, but how do I ask any of these sexual questions? And when I first started doing this, I was on a campaign to get all physicians to ask in their history any sexual concerns. 3 words. Either you can deal with it or you can refer, but just let the patient know you can ask the question, that you would ask the question. And that's fine, but it's really inadequate. It doesn't give you enough information. And so at the end of every review of systems, I ask any medical questions about any of the sexual activities in which you engage or want to engage. And I get lots of different types of questions back. But people don't know about I want to really do X and I don't know how to do it. And I'm worried that I'm going to hurt my partner. I'm worried I'm going to hurt myself. This is a place where those questions can come up. But more important, it's a place where they heard that they can talk to you about sex, and then you can, later in the relationship, they can come up and say, hey, I want to ask you about X. I want to see if I can figure out how to do this safer, better, whatever. I also ask anything else about your gender or sexual interests that would help me take better care of you. This is where patients come up with stuff about cross-dressing, BDSM, other aspects of their identity that they have not really spoken to you about in the first part of the history. And I think we all add this in some way in our histories. Anything else you think I should know about you? As I mentioned earlier, sometimes lesbians need birth control. Sometimes asexual people need birth control. It's not, do you have birth control? Do you use birth control? What birth control method do you use? It's, do you need birth control? Sexually active is actually not a very good term. I'm not sure I can come up with anything else, but you want to distinguish people who are being sexual and people who aren't. And sometimes that relates to whether you're sexually active only with yourself or with partners. And even if you're monogamous, You sometimes have sex with people other than your partner. And just because you live with someone doesn't mean you have sex with them. And sometimes, sometimes who you live with tells something about your sexual behavior. I always ask 100% safer sex. It allows me to launch into a discussion about sexually transmitted diseases and about HIV in specific. And I do this two-part question where, do you need a STD testing? And patients often say, no, I'm monogamous. And then I say, do you want STD testing? And they say, well, you better do it. Several people in my group who have picked this up are always shocked at how common that is. Obviously, we want to prevent disease, and not everyone needs all these vaccines, but it's important to find the vaccination status of hepatitis A and B, HPV, flu. Early in the COVID pandemic, there was a humorous website slide on one of the sexual websites where it showed how you can have sex keeping your mouths 6 feet apart, with people pointing in opposite directions. It was kind of humorous. But now we want to know if people are vaccinated and if they're boosted, and it's a time for them to talk about both the isolation of COVID, finding partners, and safety. I do ask any problems with erections, lubrication. Actually, I usually use arousal, orgasms, desire, pain, all of the above. A very important aspect when patients come in, especially with desire, but really with all of these possible sexual dysfunctions, are you having the type of sex you want? Too many of us have sex that we don't want, and it leads to these problems. The other aspect is, does your partner turn you on? And this can be a very difficult question for patients to say, even if they, even if the partner is not there. No one wants to say, yes, I'm married and living with this person, and they don't turn me on. I'm looking for someone who's different in some way. These are questions that you don't need. There's no way of saying, with how many partners have you had sex, that doesn't sound like you're being judgmental. In San Francisco, we often find people in the emergency room that have various objects that they can't reach in themselves and come to the emergency room to have it removed. And the ER doc goes, says, how did it happen? And the answer is always the same: I slipped in the shower. That it doesn't really help. Sometimes in sexual assault, we want to know this, but the fact is they've got this object somewhere and we need to remove it, and we're probably better at doing it than they are. Why questions are almost never helpful, and do you enjoy that is almost always judgmental. I run into a lot of issues with people looking at me and going, why are you asking me that? I came in because I have a pain in my leg, and why are you asking me about my sexual activity? And I say I ask everybody. I think it's important. In the same way, I ask them about their drug use. I often ask about sleep patterns. I ask about alcohol intake. These are important. And sex is an important aspect of your health, both medically and psychologically. And I always add, you can choose not to answer. We want to let the patient know we're open to discussing sex, and we're open to discussing it non-judgmentally. Physicians, rightfully or wrongfully, have a reputation of being very judgmental about sex. And even physicians who are trying to be open, that often sneaks in to their history, and we're trying to reverse that. You ask about sex at several points when taking the history, again, coming back to it as part of this is what we do. We're sexual medicine physicians. We take a history. Even if you're a primary care doc, you want them to know that they can confide on you. And we do want everyone to know that everyone is sexual from birth to death, whether they act on it or not. Now, when a patient comes in, and we often as sexual medicine physicians get a patient who's referred to us, they have erection problems or desire problems, and they come in and they lead with that. And I always say, we'll get to sex or gender in a minute, but first take my history. I want to get a better sense of who this person is. And by waiting a little bit, the patient seems more willing to share those details rather than saying, you know, I'm having problems with erections and I don't know what to do about it, and jumping into a problem-oriented sex history. And I'm not going to lecture you guys on how to do a problem-oriented sex history. Like any other medical concerns, that's what we do all day. But we want to do it in a more sensitive, open, a more sensitive way, allowing for other options. Now, a patient comes in and they say, yes, I know, I'm not sure how to tell you this. I don't know how to explain this problem. And this is a technique that I've developed over time. I don't need to know the specifics. But I start asking what I'll call 1,000 questions. Is this something you can do with your current partner, with another partner? And sometimes it requires a cast of thousands. Does your current partner know of your interests? Have you discussed it with it? Sometimes very importantly, have you ever engaged in it? And has anyone ever shamed you about it? Too often, we're all pressed for time, and I know that we all want to sort of help the patient along, and we guess, and we usually stick our foot into it. I see a lot of transgender patients, and a patient came in dressed, who was a male patient, dressed effeminately, who was hemming and hawing about it. And I said, is it about your gender identity? And the guy was like, just what? I'm having problems with erections. Why can't you get that? My error, my bad. Again, try not to rush the patient. It's very helpful to let them come to this on their own. They not being rushed lets them know that they can take their time to describe something that is very sensitive to them. And I hope this was helpful. And I was told to leave plenty of time for questions, so I'm about to go to the questions. And I see there's a few questions in the chat.
Well, thank you very much. That was terrific. I certainly learned a lot. You know, as a urologist, I must say that I still am very uncomfortable many times getting what I think is an adequate sexual history when the patient is not heterosexual, homosexual. Beyond that, I seem to sort of drown. And so I really appreciate all of the input. I'll start it off if I could, and then we'll open it up to all the active panelists. And you can ask the question by unmuting yourself, and whether you want to open up your video or not, that's your call. Or alternatively, you can write in the chat section a question and I'll relay it to Dr. Moser as well. But how much time would you recommend we need for the average complete proper sexual history? Understanding it depends on the individual, depends on the physician or the clinician, but what would you give us in terms of advice?
New patients are in my office are allotted an hour, and I usually get through all of the sexual history in that hour. I am told by the people above me that I'm the only one who takes an hour, and most docs do it in 40 minutes. But I think an hour is an appropriate amount of time.
One of the beauties of this sort of a virtual program, of course, is that we have the opportunity to have people from all over the world who are online listening to your talk and your expertise. In many parts of the world, Canada included, we're a socialized healthcare system, and the opportunity for us to spend an hour with a patient is really a non-starter. So if we had 10 minutes or 15 minutes, is it possible to do an adequate sexual history or not?
It's possible to do a problem-oriented sexual history in 15 minutes. But again, I really think knowing, is the patient diabetic? Does he have hypertension? What medicines they're on? All the other parts of the sexual history are important and add to what we know. I had a patient who came in with low sexual desire on Friday and didn't know that finasteride can be a cause of low sexual desire. And his previous physicians had not asked him that or told him that. So yes, it's important to know.
Thanks, Charles. Okay, let's open it up. Olga, did you have a question?
Well, hi, Dr. Moser. I am a nurse midwife and nurse practitioner in San Francisco, South Bay. And my question is, what do you recommend instead of the opening question of, are you sexually active? It always bothers me to ask this question, but I don't know what is a better alternative. Thank you.
As I said, I don't think there's a good option or an alternative question. And I sometimes vary it based on the person, the issues that I have in front of me. And I sometimes ask it in sort of a cryptic way. How many times have you tried to have sex with your partner? How many, do you masturbate as well? Usually those take more time, and when it's important, of course I do it. But sometimes the patient sort of comes in and tells you, my wife and I have tried to have sex, every night for the last 6 years, and here's what the problem is. Well, I want to know if they're sexually active with other people besides the wife, but I don't necessarily have to ask that question. Are you sexually active? You've already told me that.
Dr. Moser, how would you approach a sexual history when the partner is in the room?
So I often say, I'm asking you this question, and I know your partner is sitting here, and they will answer whatever the question is. But later, the partner is often not in the room, and they will say, I told you that I'm monogamous, but the truth is I'm having sex with, 6 other people. And that's something that we should, that we can talk about. Again, it allows them to know that that's information that I want, and allows them to understand that that's something that we can talk about, that I'm not going to be judgmental about it.
Excellent. Paul had a question for us. Paul, I'll read what you put in. He says, may I ask you some advice or to give us some tips on how to obtain an accurate sexual history in MSM for us who are living in countries where homosexuality is still illegal. Most of the time, it's a big challenge to conduct a good medical exam in gay patients in some countries.
This is a very serious problem, and especially made worse by the fact that most countries are adopting some sort of electronic health record. So you can't even, ask the patient, I'm not going to touch the keyboard and write this down, but there'll be enough clues in it that police or other people can sometimes get these records and put the patient in harm's way. And so you sort of say, I know it's illegal in your country or in your area to engage in sex with other men. Is that a concern of yours? I'm not asking them to say they do it or they don't do it, but they begin to give a little bit of information, and then literally not writing anything down about it because you don't want this to fall in the wrong hands. But one day, hopefully, we're all going to be more sexually open than we are now.
What do you do with approaching problems for patients who are sexually active and they're adolescents? They're under the age of majority. So when minors approach you with sexual concerns.
In general, you can always talk to the patient about sex, and you say things like, when you're old enough and having sex, here are some issues that you may want to consider. Also, even if the parent is in the room when you're talking, when you say, I'm going to examine you now, and so I need you to put on this gown, it opens to the back, etc., the parents always leave. And that's when the patient can talk to you more frankly about their sexual history. And there are places, at least in the United States, where you can refer patients to who are underage, who can get appropriate birth control, abortion, other advice. It's very difficult, though, even in the United States, even in San Francisco.
The American Academy of Pediatrics published a consensus paper not long ago that talked about the importance of doing a sexual history and a sexual examination for pediatric and adolescent patients. So do you have any advice to the audience here about how to approach sexual questions in the adolescents? And what sort of a physical exam do you do in adolescents? Just to give us your insights.
Well, let me just take it a little bit further in that, and I'm an internist, so I almost exclusively deal with adults, some adolescents, but I have, in my training, done a few pediatric rotations. And one of the things that you do in peds is you examine the patient, you examine their genitals, you want to make sure they're not ambiguous, there's no malformation, and you tell the parent what you're doing, all right? One of the things that pediatricians do is they'll do, their exam and say, oh, what a cute nose you have. And, oh, I love it when you stick out your tongue that way, and whatever they do. But when they get to the general exam, they're quiet. And the little kid thinks, oh, something wrong with my genitals. That's why the doctor's not saying anything. So you want to do it, whatever your banter is in examining the child, you want to go through that as well. In adolescence, I often ask more leading questions and about other things. Are your friends at school sexually active? Are you feeling any pressure to be sexually active? Do you have sex with other people that doesn't involve penis and vagina or anal sex or oral sex? Are you doing other things? And adolescents often have their own strategies. Understand that there's an awful lot of information on the internet, some of it good, some of it not so good. And there are teen sites, sexuality of teens sites that often are helpful. And they will often say, try talking to your physician about that. And they come in, I looked at the site and it said, blah, blah. What do you think of that as an entree? Early on in my career, I realized whatever it takes to have rapport with adolescents and children, I don't have it. I do so much better with adults.
Yeah, I find that hard to believe that you don't have rapport with adolescents. There was a question from Carmela. It says, this is a wonderful presentation. I would echo that. Once into the session, I transition with, this is something I ask all of my patients. Do you have any questions about sexual activity? Are you sexually active? So what do you think, Dr. Moser? Is that a reasonable approach?
It is. I mean, I had my own version of the questions, and for whatever reason, those work better for me. Questions about sexual activity often get misconstrued, especially by younger patients. They think, wearing a short skirt is a sexual activity. And sexually active, as we've talked about, is, what does that really mean? Do you masturbate? Do you have sex with partners? Do you have sex with many partners? It's a good question to ask, but it needs follow-up.
Okay. What about the other end of the spectrum? Are there special things you do or the way you approach the patients who are in their 80s, 90s, the older patient group that may have a totally different cultural background or had a different upbringing and may not be as internet savvy and don't have the resources that are available on the web? Are there special tricks you do for the older populations?
Depending on the patient's response, I often say, patients in their 80s and 90s are often sexually active and are having sex with their partners or masturbating. And I want to explore that with you. I want to ask you some questions. And that's often, again, the entree to say, yeah, my partner is no longer interested, but I have one patient who is having a love affair with a massage parlor person that he sees on a regular basis. And I don't think he would, if you ask him about sex with his wife, you get a very different answer than sex with this massage parlor contact.
Another question, do you usually ask both partners in the couple about their sexual problems? And is it obligatory in your practice? Do you do it at the same time or do you separate them?
I usually try and ask that question of the individual separately, but if they're there, I do the same thing and I say, I know your partner is here, but I want to ask you about these problems, these issues. And again, it often leads to telling me at another point about whatever the sexual problem is. Again, I recommend you don't rush the patient. And I'm just reading the next question here about sexual abuse, non-consensual experiences. I do. I didn't put this in this particular presentation.
Sorry to interrupt you. I'm not sure that everybody has access to the chat feature. So the question was about sexual abuse, sexual assault, non-consensual experiences, and how Dr. Moser manages that scenario. Please go ahead.
So I often ask a question at the end of my review of systems, basically about any history of sexual assault. Again, I sometimes in San Francisco, we have lots of patients who don't speak English as a first language, and sexual assault or non-consent is often a difficult concept to get to. And I usually try and couch it in trauma. You know, there are an awful lot of patients who are traumatized, even on behavior which is, at least on the surface, consensual. I didn't get into it because it's a bigger piece of this discussion.
And so when you end your generic first consultation session, as an example, and there are obviously some takeaways, treatment options, and a management plan, typically from a very pragmatic standpoint, what would you do as next steps? How do you usually coordinate or prioritize the treatment approach for your patients?
What I really try and do is treat the patient as a regular patient. So unless I have labs already, I'm ordering a whole series of labs. Sometimes they're esoteric to what I'm doing, but sometimes they're really valuable. Rarely do I find either hyper or hypothyroid to be a cause of sexual dysfunction, but it happens on occasion, and it's important to do that. So I tell people, I'm going to do all these labs. You're going to come back in a month or 2 months, whatever it is, and we're going to talk about the labs. And then I often have given them some ideas of what to do for their particular issue. Maybe it's giving them a PD5 inhibitor. Maybe it's asking them to masturbate, which they haven't done in years. Maybe it's talking to them about doing intimate contact with their partner, but not pursuing sexual intercourse. And then I say, what happened? How did that go for you? And we then proceed to figure out what the next step is.
Right. So my point, I guess, in asking the question was that for the participants here and for the whole general audience, this is never a one-off. It's always a process. You're going to develop an ongoing relationship with this individual. What do you think? Is homosexuality increasing in the world?
I think homosexual exploration is probably increasing. You know, if you go on the internet and everyone says this brand of soda is better than all the other brands of soda you can try, you might go to the supermarket and pick up some and see if you like it. And so I think people do experiment with it. But I don't think many people change what they do sexually, at least not appreciably, because, you know, they tried this version of Swiss cheese or that flavor of soda or whatever it is.
Okay. This is an excellent question. I wonder when a patient is exhibiting risky sexual behavior or reliving sexual abuse or trauma. How do you approach this? Do you confront them, attempt to explain or inquire about it? And in such cases, do you refer to a psychologist or a psychiatrist?
So when somebody says to me, I'm making this up, I was raped or I had this awful sexual experience, well, the first thing I ask them is, are you safe now? You know, and is there something we do to have you feel safer to avoid this activity? And then I often ask if they'd like to be seen by a sex-positive psychologist, psychiatrist to manage that trauma, usually beyond what I can do as an internist sexual medicine physician. And many times they say yes, and I make that referral. But sometimes, in fact, often they say, no, that's not, I've sort of dealt with that. Risky sexual behavior is something that happens all the time. most of us, unfortunately, have had times in our life when we've done things that are risky. I mean, people use drugs inappropriately. People decide they're going to go to a bar and pick up somebody, a stranger, and sometimes that turns out to be really bad. And sometimes it's a nothing. Rarely is it a great experience, but it happens. And so what you do is you talk about them making a you understand what it is that they're looking for and how you can change that. The old thing of, you know what they call people who have sex without protection, without birth control, parents. It's that sort of, you're taking a risk, but you know, people take risks all the time. They drive too fast. They don't wear their seatbelts. They decide they're going to go skiing, especially going down a slope that is beyond their skill level, and people get hurt. Never good to say, I told you so, but you try and give them that sense of, how can I do this safer?
I'll just relate a small anecdote from my personal experience. I was a medical student. It was about 35 years ago. I was doing a rotation in obstetrics and gynecology. And at that time, I knew I was going into urology. And I'm, as probably it's been obvious so far from my questions, I'm pretty concrete. I'm a surgeon and I fix erectile dysfunction. So some of the subtleties that we've talked about today is beyond my skill set. And it was certainly then. But I saw a woman who was in her 40s who came in for dyspareunia. She was having a painful sex with her partner and it was a real issue. And I spent a half hour with her. And then I came back and spoke to my attending physician and told him the story. And he said to me, go back and ask her if she was sexually abused. And I did. I didn't know where he was coming from, but I did. I assumed it was a lubrication issue. She's perimenopausal and so on. And when I asked her the question about sexual abuse, she started crying, opened up and said no physician had asked her that in her entire life. And it was the first time she was able to talk about the fact that she was raped as an adolescent girl. And so I was amazed at how insightful this treating physician was and the effect of experience and so on. What's your experience in that situation? So asking the right questions can have a dramatic effect on patients' quality of life.
Absolutely. And I usually get to that by, someone says, I'm having pain with intercourse. And you say, okay, have you ever had painless intercourse? Has it ever worked really well for you? And if not, when did it start? And a truism is, I always go back, they say, it started about 2 years ago. And I say, what was happening in your life 2 years ago? When did this start? Well, this partner, I broke up from this partner, went to that partner, I changed jobs, I moved to a different city. There's usually some correlation. And so then you sort of try and pull out what the issues were. And sometimes you get things like, I love my new partner and he or she is great and everything is wonderful, but physically they remind me of the abuser of when I was 12 or whatever. And you begin, obviously that's something that I'm going to have to refer to a psychiatrist or a psychologist, but you really want to be able to pull that out. And indeed, a lot of sexual abuse goes unreported and patients are afraid to ask or tell their physician that. And physicians, by their body language, are often afraid to hear it because then they don't know what to do.
Right. You've opened up Pandora's box. I meant to ask you this myself, but when you were referring to the importance of your staff in the front of your office and the scripts that they were given by you in terms of dealing with patient and patient issues, the question was, are you willing or able to share some of those scripts with the people that are participating in this event?
I'm happy to send you a couple of scripts that I have. since I'm not the one repeating them, I'm afraid to do it from memory, but they usually go something like, I know you're calling to make an appointment with Dr. Moser. Did you know that he's a sexual medicine physician and he treats, and then they have a variety of sexual dysfunctions and people who are uncomfortable with their gender or sexual orientation, and they have a long list of things. And so they let the patient know that if they're coming in, I'm going to raise those subjects. And I have some patients who come to see me and they really don't have any sexual concerns, but they need better control of their cholesterol or diabetes or whatever. And some patients, they don't care that I'm going to ask sexual questions. And I'm sure some patients say, I think I'm going to go find another physician, take care, and move on.
Excellent. Do we have any other questions from any of the participants? If not, we have a little more than 10 minutes left. What's been your greatest challenge so far in clinical practice, Dr. Moser? Which patient population do you find the most challenging and which do you find the most rewarding?
If I can just change the question for a moment. When I joined one of these medical foundations, and they allowed me to pick my office manager, who was a lovely woman who was a nurse in the hospital, and she was great. And she would go to meetings with the other administrators, and they would all introduce themselves, and she would say, I work with Dr. Moser, he's a sexual medicine physician. And they would all go, oh, him. You know, there were lots of patients who were, lots of administrators who were just uncomfortable that that was part of their issue. And I had interactions with the electronic medical record people who would say, there's no room to ask these questions on our sexual history. We can't put pronouns on the banner headline of all this. And these were the biggest fights that we had. And you know, and I was very candid. I said, if you can't do it, then you need to find a computer specialist who can, because it's a computer, it'll do what you tell it to do, and let people, you know, I'm sure, running out of the room screaming and holding their heads. Possibly the most rewarding patients are, you know, we have lots of physicians who are really good with straight couples and gay couples, but the BDSM couples, the cross-dressers, the cuckold couples, those are people who really go, I can't believe you were able to get me to tell you this. That's, of course, the very, very satisfying. And we try and figure it out.
Excellent. You know, in our system, my operating room days were typically Wednesdays and Thursdays. Wednesdays, I do general urology, but on Thursdays, I would do mostly penile implants, reconstructions, and all of the nurses and the staff would call it Penis Thursday for about 20 years. The next question is, how do you make a diagnosis when a male patient is hypersexual?
Well, that assumes that hypersexuality is a real thing, and I'm not so sure of that. And I often get referrals from patients, from other doctors who say, I think this patient's hypersexual. And over a period of a few interviews, it's pretty clear that the patient is not, or that this is something that the patient really is struggling to work out in their lives. The best example is teenage boys who are focused on women's breasts, all right? And if you then show them pictures of women's breasts, this gets difficult if it's a true minor, but you then show them and you talk to them about it, that dissipates pretty quickly. Yes, there are people, you can become obsessed about anything, and sex is one of those things. But if you don't assume it's sexual and you treat it as obsession or compulsion, OCD of one form or another, those often go away. I'm actually a little, many of my sexual medicine colleagues think that I don't give enough credit to sex because I ask about all these other things as well.
If you could ask only one question of the sexuality in the pre-questionnaire paper, what would it be?
Are you sexual? Any sexual concerns?
Okay, that's good. But the beauty is that you should never really be in that situation. You should always be in a position where you can ask the question, the appropriate number of questions that give you the answers you need to get. I think that what Dr. Moser has taught me is that regardless of what that patient looks like or what they say initially, it's important to get as much of a complete sexual history as possible by asking a series of right questions that'll drive you down the pathway to hopefully help that individual or that couple.
Yes, thank you.
So are there any other questions? Please feel free to put it on the chat room. I must say this has been a wonderful session. Just as a bit of advertisement while we're waiting to see if there's any more questions. Next week, Dr. Bud Burnett is going to do the next Ask Your Expert, which will be on priapism, which is quite a departure from today's talk. It'll deal with prolonged penile erections, some of the physiology, management, surgical options, and medical therapy, as well as some of the basic research. Many of you know Bud. He's from Johns Hopkins and has been a world thought leader in treatment of priapism now for many years. And that's part of the European Society of Sexual Medicine, where the ISSM is holding an Ask the Expert webinar with Bud as the lead. We have an excellent group of panelists, including David Ralph, Atesh Kagudulu from Turkey, as well as many other real experts in the field. So I'm hoping that many of you who are on tonight may be able to join us for the next one in a week's time. It looks like we're almost out of time. We're out of questions. Oh, here's one. Do you have any forbidden questions that you avoid asking?
No. Simplistically, no.
Okay. I would have guessed that would have been the answer. I think that an open mind and an open dialogue is really critical to success. So with that, I will thank everybody for joining in on a Sunday morning, afternoon, evening, depending on where in the world you are. Dr. Moser, thank you for a wonderful presentation. I know it was a lot of work to put it together, and we all learned a lot from your expertise in this really interesting and evolving topic. Thanks again, and have a good day, everybody.